Good morning, or should I say good afternoon? For some of you doesn't know me, I'm Efi Shemesh, the sales director for Asia and Africa. And thank you for joining us to this webinar, Modern Endo Suite ESWL. Let me introduce some important people in Medispec. The CEO of Medispec, Mr. Avner Spector. Just raise your hand, please. And the VP Sales, Mr. Lior Cohen. Also, the medical director he should be beside Avner. Anyways, a new medical director we have, Mr. Dr. Alex Slutzker. And regarding the webinar, please wait with the question until the end of the presentation and write a note. You have an option to write a note, and then at the end of the presentation, Avner will answer one by one. I hope you enjoy the presentation, and please, Avner, go ahead.
Thank you very much. I appreciate your time to be with us. It's a pleasure to present it to all of you, even few of you know me quite well. And as you know, I have more than 30-year experience with ShockWave lithotripsy and kidney stone disease. And I would like to share in this opportunity the view of Medispec, how it's need to manage stone center and which way to go for it. So we change from lithotripsy, the way to talk about it. We're talking about endo-urology suite and stone management. And when we talk about it, and what we'll talk in this presentation is about Medispec, about ESWL lithotripsy, lithospec, laser, and clinical case study to see where to use all of them when we're talking about stone disease and how to take care of it. A little bit about Medispec. Medispec founded by me in 92. We are nearly 30 years exist. And we are one of the leading in shockwave therapy, especially in low intensity shockwave like erectile dysfunction and any field in urology, orthopedic, cardiovascular. We are a global company that we have more than 2,000 devices all over the world. So we have very strong presence and know how what need to be done and which way. Obviously, we have FDA and CE mark, and I can say easily that with our devices, they treat more than 1 million people in kidney stone during their life. So I believe that's our device have a lot of background and knowledge. A little bit what other products we do. We definitely do the lithotripsy, the ED1000 for sexual erectile dysfunction, and the cardiospec, and as well as the aesthetic and the orthopedic thermotherapy for beginning prostatic, and obviously for veterinary. But we today will concentrate our talk mainly in the lithotripsy and the stone disease. Why we change our mind from talking only?
Now?
Yes.
I'm afraid we don't see the presentation. It's not shared yet.
Oh, we don't see the presentation. No, it's up a lot, okay. I believe. So I will go a little bit back. Sorry for this. When we talk about endo suite or lithotripsy, We'll jump on this, we'll jump on this, and we'll be back on this. For our equipment that we'll see, sorry for this. Obviously, we talk about lithotripsy, the ShockWave lithotripsy, the erectile dysfunction, the cardiospec, aesthetic, and also we have the orthopedic and microwave. But when we go to talk about endourology suite or lithotripsy, basically we talk about the main component that's important is the treatment table where the patient exists and the imaging system. And that's why we believe today is more to call it endo suite, because this is the main thing that's important. And when you have those components, you can go further. But now we'll go for the lithotripsy and what is ESWL. So obviously, as we say in endourology suite, the first step is to have the endourology treatment table that's allowed you to do also the lithotripsy, because you have the notch, as you see it here in the corner, that's allowed to ShockWave to penetrate. It's important to have it in both sides, that you will not need to change the position of the patient, the head of the position, according to the side of the kidney. And this is the basic for any endourology treatment, as well as lithotripsy. Obviously, we need to see the stone, and for the stone, and for sorry for that jumping like that, apologize. Obviously, for seeing the stone, we must have imaging system. The preferred method to see the stone is, for me, is the X-ray. Even it's a little bit more expensive than ultrasound, but much better quality. And even when you go to endourology, you must have this in your capability, because part of the rule when you do endoscopy, it's to see where you are located related to the stone. So in any way, those two criteria, it doesn't matter if you're talking about lithotripters or endourology suite or endourology procedure. But in this case, we're talking about the ShockWave. When we're adding the ShockWave to this configuration, we create full extracorporeal ShockWave lithotripsy. That's you have the ShockWave source, you have the treatment table to put the patient, and you have the imaging system. But in the same way, as you see here, you can also add a ultrasound capability. So from imaging aspect, you can have ultrasound capability as well as X-ray capability. And sometimes, especially for very heavy duty things, people like to have a control room that you can make it from remote control. And for this way, you have the medic console that's allowed you to control everything from long distance. So all of these together create a lithotripsy, what we call the full package. And obviously it could be with any configuration that you want. Now a little bit about the technology. When we're talking about lithotripsy, everybody knows that we're talking about ShockWave. ShockWave is a pulse that's of pressure, acoustic. It could come up to 1,000 atmosphere. And the existing, usually it's less than 1 microsecond, and rise time is usually need to be near the 300 nanosecond. And we need to remember that it's a move in the speed of sound that's in the water or in the body is 1,500 meters per second. How we create the ShockWave and how we do the mechanism. If we talk about spark gap technology, we have the reflector. In the reflector, we have a spark plug. We create a spark by putting high voltage in the water between the tip and on the electrode and create some kind of exposure. This exposure go to the reflector and concentrate to the body whenever we want. And all what we need to do in this stage is only to put the stone and the air that you want in the distance, in the right location of the focal, to take care to have coupling, a good coupling from those things. and between the ShockWave and the body, and then we can get a good fragmentation. Obviously, there is other source to make a ShockWave. It's not need to be a spark gap alone. And we, as the company that's leading in this field, we believe very strongly that we need those two modality to be available. So we have the electro-hydraulic technology and we have the spark gap technology. Obviously, we need to combine all of this together, and this how it's a full loaded of a lithotripsy system. That we have the treatment table, X-ray. They have a few versions of X-ray if you want a special one for lithotripsy or we want for multi-purpose, and this depends on the need of each clinic. And obviously the ability to do the treatment with ultrasound or a combination between to find a stone with ultrasound, X-ray. If somebody want to reduce X-ray exposure as well, and sometimes that's when we have a cystic stone or something like that, a radiolucent stone, then obviously ultrasound is nearly the recommended way, even if you can use a contrast material in the body to see the stone by X-ray. Each one is an option that we can choose. Obviously, there is other way to do to destroy the stone in the kidney. We can talk about the laser future, and the laser in this aspect is comparable to the ShockWave, but it's internal. But there is another way to do internal, and it's even much less expensive, is using the device of the ShockWave, intercorporeal ballistic ShockWave, what we call the lithospec. The advantage of the lithospec is very cheap, low-cost device, very efficient when we're talking about bladder stone, percutaneous, lower and middle ureter, but they have the limitation that you can't use it with flexible scope. But this is an option whenever you're talking about which way to disintegrate the stone. Basically, we have the internal option, like laser and the lithospec, or external by ShockWave lithotripsy. And we will take some time later to talk and to discuss which way will be the best way to deal with with each case of stone and to decide where to go. But again, the most important when we talk about it is the endourology treatment table, and that's why we see it as a very strong aspect, and we improve our endourology treatment table. And what we think that's important, that's anyone that's open urology center, it's important to sell our endourology treatment table, because this is the only way that he will be able to add after that the ShockWave in a simple way and easy way, that he will not need to change anything. Obviously, he can buy his own X-ray or can buy from our X-ray. Part of the good things about our equipment, that's we can work with most of the existing X-ray system. So it's not a mandatory to buy from us the X-ray. So for example, if a urology have a mobile CRM and you want to open a center, you can buy only a treatment table. The next phase, you can buy the lithotripter, the ShockWave device, and in this way you can get an endourology suite with all the options, and to do it step by step. It don't need to be in one time. Clinical aspect, when we talk about ShockWave lithotripsy, we need to see what's supposed to be our expectation and what we should do. And we need to remember that even we use chassis for this purpose. When we talk about lithotripsy, and even if we talk about intercorporeal, the issue is to deliver energy to the stone, and it's acoustic energy. Because also the laser creates some kind of explosive near the stone that creates the pull pressure, and obviously the lithotripsy, that extracorporeal, do it from outside without penetrate to the body. And when we talk about the lithospec, again, it's give mechanical impact on the stone to break it. So obviously the energy is important. And what we want to do is to break the stone to small pieces. That's or will go out normally, or even we will flash it during the treatment if you do endourology procedure. But so this is important. And when we look about a stone and stone location, basically we need to look on the urinary system and to see where we want to be, because we can start with some bladder stone or in the ureter. In the ureter, usually we break it to lower ureter, middle ureter, upper ureter, and also in the renal pelvis. If we're talking about the renal pelvis, we're talking about two aspects. First, the pelvis himself, and then in the calyx, you can have the upper calyx, middle calyx, and lower calyx. And in each case, we need to think separately what will be the best way to do it. It's important according to the size of the stone, type of stone, and all those, and also important to see that the urinary tract not obstructed, because if it's obstructed, for example, we will break the stone here, but it will not pass through the ureter, so it doesn't done anything. What we should expect, and I think the only way to go to realistic, what is the expectation, is to go historically what all the company when we start, the lithotripsy, it was in USA considered a PMA product, and that's why they done a thorough study that's not biased by any direction. And that's give us the ability to see what is our expectation from ShockWave lithotripsy if it's done properly. We are happy to say that Medispec here, we succeed to achieve the best result from any other company in the market that was been at that time, to come nearly 83% success rate. Obviously, it's dependent on the location. Sometimes you can get higher and lower, and a retreatment rate of less than 7%. So it's a very good result and need to be considered in the right place as the first line. Dornier even got lower, Siemens lower with a lot of retreatment, and Storz also got lower. But as we see, doesn't matter which machine we are used, will be more than 65, and we expect to get in average up to 83%, and we're supposed to have between 7 to 30% retreatment rate. And so if we choose the right stone with the right device, we can get even higher. That's the need, make it as need for the first line of treat stone. Professor Lingelman from USA invested a lot what is need to be the important aspect when you're talking about success and what is the parameter that you want to get. So the first parameter that you find that's a large focal zone in lithotripsy are more effective. And also very important, the coupling way, how to do it properly, because otherwise it's destroyed. And also very important part is the frequency. Low frequency give a good fragmentation result. So we're pleased to say that we have when we're talking about the electro-hydraulic, we have the biggest focal area in the market. That's we have 13 by 60. We have a maximum pressure of 910 bar. And this is very important factor that need to be understand. Sometimes people think that higher pressure give the best result. And this is not necessarily the right way to look when we look about all the equation, what we want to achieve when we do a fragmentation. In one aspect, we doesn't want to make a side effect. And when you go higher than 1000 atmosphere, you start to make more damage. Obviously, if you go to high frequency, that's also something that's could create more damage and reduce the efficacy. That's why it's one of the recommendations to work in low frequency. In low frequency, we're talking about near the 90 pulse per minute, 60 pulse per minute if it's a very big and tough stone. But if somebody go to 140, 180 is pulse per minute, it start to create more damage and reduce the efficacy and need more shot to finish the treatment. And this is very important when you do your lithotripsy to remember those rules. Why is the big focus areas important? Because we know that's one of the issues that exists during treatment is the respiratory, that's move the stone, if it's natural or do it by ventilation. That's a very important factor. So obviously we need to look of 3 types of stone and also 3 types of or 2 types of focal diameter, as well as different movement, because we know that the reality of no movement at all not exist. Unfortunately, if it exists, we have the wrong patient. But if we take a movement of a ½ centimeter, we can see the difference in this way. That's a small stone like a ½ centimeter will go out from the focus. So it's mean that 30% of the shockwave that you do go for no purpose and just make damage to the kidney without doing anything to the stone. And if you go on 1 centimeter stone, you already see it that it's still in the focus and this is still visible, but half of it you don't treat. But if you have a big focus, still all of it is treated. So basically, even if you have a ½ centimeter, something that's visible to control, you can still do it. And if you're talking about a big stone, it's not matter. But if we have a 1 centimeter movement, what you see here, we also out from 1 centimeter stone, and this is a typical stone that we want to treat in the kidney. And even if you talk on a big stone, you need to think twice where you want to put your location and where you do, as long as you do it with a big focal area like ours, you treat all the stone all the way, and then you get the maximum efficacy. And you need to remember the 2 things. As long as we're below 1000 atmosphere, as much as we have a bigger focal point, we have a better chance to get a better result with not making damage to the kidney. As long as we do it with a low frequency, below 100 pulses per minute. And sometimes it's recommended even to go below that. So remember, not all the time to do it, to make the machine work faster, it's make it faster, it's only make more damage. And for this, there is a very physical explanation that each shockwave that's passed through the tissue creates some bubbles. Those bubbles, they have time to observe by the body. If the next shockwave comes too fast, it's mean high frequency, you see area, and that's what make the damage to the tissue. And again, we go back to the main question when we talk about extracorporeal shockwave lithotripsy, that's if we want to have electromagnetic or we want to have electro-hydraulic. And again, I don't have a clear answer, and each device have its own benefit, and each clinic needs to choose according what they want to do. Electro-hydraulic, usually it's more efficient, much more noisy, and put more burden on the operator to replace electrode between each treatment. The electromagnetic, you have the electromagnetic head that's you don't need to replace it between patient. It's much more quiet device, so obviously it's much more convenience to the treatment, and it's put less burden on the operator to replace electrode. When you're talking about the cost of operating, in the end there is no big difference, because the electromagnetic head have a lifetime that you need to replace it. And if you calculate those aspects, you get the same cost approximately like electro-hydraulic. So the decision to choose which kind of device, each one know in his area what is the type of stone that exists and what the doctor prefer. Usually if they do it with a small stone and not very tough, electromagnetic have the advantage is good enough from clinical aspect, and it's much more convenience to do the treatment. So this is a question, and we as a company that's leading and control those two technology, believe that we can give each customer the option to choose what it's more fit to his requirement. And again, when we talk about stone fragmentation, the success rate related to precision of the performance of the technician. If we do it properly, we get much better result. If we do it less, we get less result. For example, one doctor from Nepal, long time ago, complained that the device we are not doing good treatment because we have only 20% success rate. And I asked him, what is his procedure? And he said, I take care that the patient will be fasting 24 hours without drinking before the treatment. And I told him it's the wrong way that you can do it, because it's important to have the stone in water surrounding. And if you do it this, you need to give them infusion at least half a liter or 1 liter before you do the treatment. And the same physician met me in a next exhibition and say, you don't believe what it's done. I moved from this low rate of success to more than 95 rate of success. So patient preparation is very important. When you prepare the patient properly and know what you're doing, usually between 1,000 to 3,000 shock will do the job, definitely with electro-hydraulic. In the urethral stone, maybe no, you'll need more. And if you have electromagnetic, usually it's more shock than electro-hydraulic to get the same result. Pulse rate, definitely 60 pulse per minute, it will be the best. But even 90 will not see a big difference, and that will give a good result. Real-time imaging during the fragmentation is very important for all the reason in the world, to see that the patient doesn't move for any reason, even to see that sometimes big fragment from the stone disconnect and move a little bit in the kidney. If you are not looking for this, you forget it and not treat it in the end of the treatment. So this is very important. And usually you can do most of the stone or even most of them. Even so that cysteine, sometime I recommend to think to change the diet of the patient. It could be disappear, but this is more soft stone, so the fragmentation rate is low. Stone density, size, and distance from the skin, all those are parameters that influence the treatment and how to do it. But when you do it in the right way and you prepare it properly, it's supposed to get a good result as expected. Now we come to one of the biggest questions that exist. Do we want to use laser or ESWL? Laser, I'm calling any type of intercorporeal lithotripsy. It could be laser, it could be a lithospec, it could be ultrasound, intercorporeal, any way that you can do. And the question is still exists, but at the moment we concentrate a lot about the difference between laser and ESWL. Both of them, when we look in the right way, we need to look about the source that disintegrate the stone. It's mean the laser machine with the fiber or the ShockWave device, because in any way we need to use the Endo suite. It's mean the treatment table and the X-ray system. And in this case, when we are looking and we want to separate those aspects, suddenly it's very interesting that the price of the lithotripsy without the treatment table and the X-ray is nearly equivalent to the price of the laser. I know that in your territory you can find from China lower expensive laser and lower expensive ShockWave. But when we're talking about good quality, that's nearly the pricing that we can do, and that's why it's nearly equivalent. So one of the main issues that people say, lithotripsy extracorporeal is more expensive than laser. I would say no, you're wrong. Even when we're talking about the capital aspect, how much you pay to buy the equipment, it's the same cost. But it's very interesting when you go to the cost of operating, and here suddenly it's come a very interesting aspect. If you compare the cost of consumable, we already agreed that the price of the device, they are the same. So the cost of consumables, suddenly we have a very interesting comparison. When we look about the cost of electrode or the cost of electromagnetic ShockWave per patient, it's less than $60 per patient. But when we look about lasers, suddenly the number becomes totally different. They are coming totally different because we have the fiber optic system, the endoscope, especially when we're talking about flexible endoscope, it's make it very different, and that's make it very important to show this comparison. So we have the fiber optic, it's nearly between $200 to $50 to $200 to repair them. The fiber optic himself directly is approximately 139. Everything we take from literature, so could be in your place is high or low. But the most important part is a fiber optic repair, because the cost of a good flexible endoscope today is nearly $15,000, and usually it's nearly 10 to 20 cases. So in the literature, it's, today they take it as a cost of $956. Let's put the total cost of consumable per procedure, $60 vice versa, 1,000 up to 1,350, and suddenly the laser become much more expensive device than the extracorporeal lithotripsy. But another factor that people don't take it in consideration when we look on other parameters of the procedure. The treatment time in lithotripsy, it's between 20 to 40 minutes, and laser usually it's between 30 and could come even up to 4 hours sometime when you have a very big stone in not convenient location, like in renal pelvis, in the lower calyx together, something like that. Another thing that's very important is the number of days that you need to be in hospital, and that's you have in laser lithotripsy is 1.2 and 3.1 in laser. And when you take a $1,000 as the average cost bed at a hospital, then you have a big different cost in this aspect. And when you combine the two factors, the 3 points regarding this matter, cost of the device, the same. Cost of consumable, laser much more higher. Other costs related, much higher. And when you're talking about, and if you're talking about complication, then you have much higher complication and risk factor. All of this together need to make people think twice which way to go. And another thing that's important, the lithotripsy could be ambulatory, and today with the corona disease, it's something that needs to be seen twice, and this is opportunity that people want to move stone center to do a outpatient base or ambulatory procedure or something like that. Obviously, the lithospec could get the same effect as the laser, much less expensive, and it's very good when you're talking about bladder stone. It will give you much better effect in percutaneous, and in the lower and middle ureter, you have a big advantage. If you want to do a laser, lithospec, your cost is going down to $10 sterilization, and the treatment time with Lithospec it's much faster than any other procedure. You can do it in 5 minutes, something like that. And if you have a big bladder stone, you not work more than 10 minutes on this. So it's much faster than the laser. Have the limitation that it can't work in flexible scope, so it can't go up to the kidney to treat stone in the kidney unless you do a percutaneous. A little bit we'll go to clinical aspect and to see what from clinical what we want to do. Again, what we're talking now, it's not related to our equipment or any other equipment. Obviously, to do a good stone fermentation and disease, we need to see good the stone. So obviously there is the ultrasound imaging in the right side of the picture, X-ray, the way that you see the same stone in the X-ray, or also in the location of the urethra. You can see the stone and you can see the location. This is the first factor, and when we try to go to see to do any kind of treatment, that's something that we are taking in consideration. What I want to show you here they use construction to see the kidney and the urethra, and this is very important to see that you don't have any obstruction in the kidney, in the urethra, because this is the first things when you see a stone in the kidney to see that the urethra is open and the fragmentation will be able to go out. As well, if this is a patient that's potential to go with endoscopy, because if the urethra is obstructed, definitely we need to go on percutaneous. We don't have any other way. So in this case, the consideration of a ShockWave lithotripsy, vice versa, laser in endoscopic procedure is not realistic. So the question, which way to go, PERC, laser, or ESWL? If you see this Tigon stone, this Tigon stone is very big. It's, I believe, from here to here, it's at least 3 centimeters, and from here to here, it's again 3 centimeters. We see it upper pole and middle pole. The question, if it's need to be lithotripsy, PERCs, or laser. It's a good question. If you go according to the guidelines today, it's a little bit big to do lithotripsy, and I don't sure it's correct because we know Tigon fragment very quickly, and if you do the first treatment, take the lower part here, and the second part will do this, we have a good chance to finish it with 2 sessions and maybe 1. And we need to let the people go and to do it. That's one way. If we go with laser below, that's something that's it's a very big stone, and this treatment will take 2 to 3 hours at least to fragment it, and 2 to 3 hour fragmentation, anesthesia to do the treatment with full sedation, we increase the risk factor for the patient. To go to percutaneous, it's a little bit invasive, and then percutaneous, it will be difficult. For example, if you get percutaneous from this side, it will be difficult to the upper pole, and if you go from the upper pole, it will be difficult to go to the kidney. So a lot of time, it even could be a combination that a doctor could decide this classic to do a percutaneous. We take most of the stone in percutaneous, and the next treatment we will do with lithotripsy to finish cleaning the stone and all the fragmentation that's left over at this pole and this pole, and maybe some from this pole or from where we come, and that's also an option. So again, when you see it, you see it's very important to have a full capability to do the stone disease, to have the ability for percutaneous. That's why you prefer 5-axis treatment table when you have a good endourology suite, as well as laser option, lithospec option, and a lithotripsy option, and to be able to use all of them during the course of during the lithotripsy. The next case is a very look like a simple case. Let's say we talk about a kidney stone in the middle ureter. We know that the success rate is very high. It's less than 1 centimeter. As it's it's not stuck in the tissue, so we're supposed to have a good success rate in lithotripsy. It's near the size that you need to think twice which one you want to go, laser or lithotripsy. For lithospec is a very classic way. So that's depend on the nature of the hospital, because if your hospital do your treatment in heavy sedation, not with anesthesia or full anesthesia, then definitely there is a lot of advantage to try to do this stone, first of all, with lithotripsy, and secondly, to do it to see what will be and if it will fail to go with a laser. But if you do full sedation in the hospital, then to decide which way to go, it's nearly the same time, this kind of stone, to do lithotripsy or laser, or use the lithospecs, or any one of them is a good decision, and that's the practice of the specific clinic and which way you want to go with this, and this is correct. Here we have a case of in the lower calyx, lower pole. It's a good question. Do we want to treat a stone like this with lithotripsy, laser, or percutaneous? So if we talk about 12 millimeter stone, percutaneous, I think it will be the wrong direction, as long as I have a lithotripsy or I have a laser with a flexible scope. Definitely the lithospec will not be right, because the laser need to go from the bottom up, the lithospec can go around, and when you talk about this, it's not something that it will go. But the success rate with this size of stone, that we see that it's not locked in the tissue because we have the space here, could be very good, and very good success rate with lithotripsy, but as well as good rate of success of laser. So now we can look of the very interesting conflict that we need to decide what will be the right way and which one is the right way, and what we want to suggest to the patient. And for this, it's debate, and there is a way to say that there is 3 types of patient in survey that's done between physician, and for this kind of stone, it was very interesting. And the first aspect is what you will do if it will be one of your family member. So for this kind of stone, the recommendation to go to laser, because for the family, it must be finished in one treatment. Doesn't matter how many complications will have to the patient. The complication is part of the procedure, and stone-free rate, it's my capability to do it. If it's to be a regular patient, I will give them the 2 options, and I will let them know that if we go to a lithotripsy, most probably have a 20% that you will need to retreatment, and then we'll see according to the result what we want to do. But it could be ambulatory procedure and less complication, less time of anesthesia, and all those things. Choose your option, and this survey done with the Americans, so usually they convince them a little more to where they do more money, but this is a different story. But when they talk the same group of physicians, what you will do for yourself, they say, first of all, I will go for kind of stone like this to do a ShockWave lithotripsy, because this is the less risky, the most convenient, and less trauma to the body. And I will see after that, according to the result, I will decide if it's need more treatment. And I think with this stone, we see the main dilemma that exists for the physician: what will be the best modality to treat a patient. And as we know, let's say in most of the time, the question what will be the right way to do is not exactly defined. And obviously the patient have a lot what to say, because in the end, he's the one that's go the procedure. But if I want to summarize a little bit this aspect, I could say that, for my opinion, between 20 to 40% of the stone is very clear if there is advantage to do it with a laser or any intercorporeal procedure. And the same number is very clear that's the advantage to do it extracorporeal. Between 20 to 40% is to do it externally. The other between them, and you can say that it's between 60 to 40%, there are the question that it's debatable, and each way that you will go for it, I will not say it's not correct. It's all the question related, how it's reimbursement, what is the cost, and all those aspects exist. And we know that there is a lot of countries that are very sensitive to the cost, and then it's a good question. And a good question, where is the location? Because, for example, I can't say that intercorporeal is not right, because if you're talking about lower ureter and you use rigid scope and you use lithospec that doesn't break the scope, then your cost to do it is very minimal, because the cost of sterilization is minimal and the cost of the equipment and the consumable is minimal. So again, this question is a good question, and each facility, each hospital or clinic need to do their analysis and to choose their philosophy, and definitely will be more than help to help you, to help them. And one of the purpose of this presentation is to go on all those aspects and to show you the whole side of the lithotripsy and the kidney stone disease, not all of them, most of them related to fragmentation according to the type of the equipment, and give more open mind to see where to go and what we want to do. So I want to use this opportunity before I will start to answer questions to thank you very much for being here, and hopefully I wasn't boring you too much and give you positive information, and that will help you to support your customer and your patient if there is some doctors here. And I'm more than happy to answer any question that exists.
Okay, so first there is a request to have the presentation. So no problem, I'm going to send each of you the presentation as well the recording of the webinar. So Mr. Avner's first question, it's actual question. How the coronavirus, the COVID-19, influence using of lithotripsy?
It's interesting what changed the trend in the market. Today, when hospital doesn't want to see patient not for a long time, and definitely they want to eliminate sedation and they try to move everything to outpatient-based procedure, obviously the lithotripsy is the choice to do it. It's a shorter procedure, doesn't need a full sedation, and doesn't need to be in recovery for a long time and all those things. And I could say, for example, one of our big clients in USA, Chesapeake Bay, they do the stoneless routine in outpatient base. They do in a day of lithotripsy something like 8 patients a day, and they argue that they not happy if the overall turnover between patients is more than 49 minutes. So that's mean that the time in the theater when they do the procedure is minimal, as well recovery, being in and being out, and that's obviously influenced a lot, and we see it in USA even in the Corona time, that they're looking for more and more lithotripsy and asking for schedule more due to the fact that they do it outpatient and they reduce the number of laser procedure. As well as we see that hospital ask us and ask some of our dealer, and I believe also you have some experience, how we can move it to outpatient-based part of the hospital than to go from the theater, what a lot of time they do, because when they do usually endoscopic and those things, they lock 1 or 2 or 3 days in the hospital, in the theater, and suddenly they think more and more it's important to go to ambulatory part. So they're looking more and more to see the endosuite, how the endosuite could do also stone disease and how to do it. And then this is our opportunity to get inside and to present this option. So definitely we see this trend and this influence based on the aspect that nobody wants to see patient in hospital during the Corona period.
Okay, thank you. Next question. Is ESWL can break lower ureter stone? What is the solution for lower ureter stone?
Of course, there is lower ureter stone. It's easy to do it, and it's not complicated in one aspect, and it's very complicated in the other aspect. The reason that a lot of physicians try to eliminate to do a lower ureter stone is because if you go on the ureteral tract, if you go over here, it's good that we have the presentation. If we look here, when we talk about lower ureteral stone, we're talking that the ureter go on the back in below, and suddenly from this area it start to go up to the bladder and get inside to the body. And if we put in this size the hip, the distance to go from here to here become low, big, and that start to make it complicated to position the lithotripter to the area to find the stone. So for this there is two options. First, to put the patient a little bit on the side. Secondly, to put the patient to line on the belly and to go from below, then it's very easy to do. But if you do a full anesthesia, full sedation, full anesthesia, obviously the doctor that takes care of the anesthesia will not be happy and he will let you know. So the other option is to do it like what we have in the electromagnetic, that's the head is going up to the top and you go from the top. So still the patient lying on his back during the procedure and you can do it very easy. So in this aspect, there is no technical reason why not to do it. But from the other aspect, if your hospital in any way do a full anesthesia, not only sedation, then a laser or lithospec could do it very quickly and very fast. In this case, the time to do it is nearly the same in those procedures because usually lower ureteral stones, they are small and they could go quickly. And so the decision is mainly according to the mentality of the hospital. If you try to eliminate full anesthesia, definitely it's recommended to start with extracorporeal lithotripter. But if you do anesthesia, then you need to think to see according to the equipment and which way is the right way to do it. But there is no physical limitation in this aspect.
Thank you. Another question. Which is better technology, electro-hydraulic or electromagnetic? What do you recommend?
It's a good question, and I try to be objective as much as possible. Definitely, we are producing the two methods. Each one, whenever you have a technology, each technology have the advantage and disadvantage. And whenever you talk about advantage, in the same aspect, for this aspect, the disadvantage exists. The advantage of the electro-hydraulic is very important in the fact that you create more energy in the shockwave head, and then you can make a more energy per stone go to the kidney area, and you have a bigger focal area. So then it's not give you much higher pressure. You have a better area to treat, and we already saw in the top the advantage of using a wide focus area to treat the stone. But this is one aspect. The other aspect is more noisy and more complicated for the operation. And if you're treating mainly small stone, then the difference between those two devices go and reduce the distance in this aspect, and they are quite similar. So in some of the stone, I don't see a big difference between the two devices. Some stone, there is the advantage to the electro-hydraulic. For maintenance aspect, usually electro-hydraulic is much more simple than electromagnetic. So it's a question more for the policy of the hospital, and there is no clear answer that you can say this is better and this is worse. It's each one need to see what is his decision. It's like is a sport car is better than a family car. It's depends. If you have a family, it doesn't matter. But and if you're young and bachelor, most probably you prefer to have a sport car. So it's a question each one according to this is need, and I see that equal technology, and we have the advantage that we can offer both of them.
Okay, good. We have both of technology, both of them break the stone. Next question, how important to combine the ultrasound in ESWL treatments?
I don't see it as a major aspect. It's I see it more as a luxury, because all the stone you can treat with X-ray. For when you're talking of radiolucent stone, it's a little more complicated because you need to use a contrast material. And the advantage when you have a combination that you can actually look all the time on the stone in the ultrasound and do the targeting via the X-ray. For X-ray, do the treatment, it's much more easy and much more accurate, and you need to be less expert. I saw a lot of time that people a little bit make miss the stone or don't targeting properly, and I will a little bit explain it. Because here we see ultrasound. I hope that you see my cursor. You see my cursor? Okay. So here we see it with ultrasound image. If you are not have enough knowledge, and this is a good picture that you see very nice of the stone, usually it's much more difficult. If you don't have a lot of experience, you will think that this bright area, this is the stone, so you target to this area, and it's wrong. If you see the same stone here, the stone is here, and actually you see this part is the surface of the stone. So when you do an ultrasound, you need to know the direction, and you need to target your position somewhere here below the main aspect, and you have the shadow. But this is a good picture that you see it very nice, and here you see how much it could be more difficult and make more ability to do mistake. Usually it takes longer time to do the procedure, even for a good expert, to do it with ultrasound. And we need to remember that's one of the main aspects that people say why we want to use ultrasound is to reduce X-ray radiation. But today the quality of the X-ray system is like that that if you work with standing in distances of less than half a meter from the area of the stone, you will not get any X-ray radiation as long as you don't put your hand in the path or your part of your body in the path of it. So actually the radiation today is very limited and doesn't make any damage to the people. So even I will not say it because regulatory is instruct you to have the bats to see the level of exposure for radiation and as well the entrance to eliminate radiation. But the reality, if each one will check his tags, they will see that if they do only lithotripsy, there is no radiation on the tag. So it means there is no radiation. So the issue of radiation is not exist. So now I will ask, in my point of view, what is the most accurate way? I would say definitely the X-ray is better. Now, if I have the luxury to do whatever I want, obviously I would be more than happy to do it with the X-ray. And during the time that's the machine working, to put the ultrasound, see the stone in the right way. So I have doing imaging to see it during the procedure of the treatment and to reduce some X-ray. But definitely my priority is first to go on X-ray. When you have a cystine stone, this is the radiolucent actually stone. This is the only one that I maybe will go only with ultrasound.
Thank you, Avner.